Everyone. And firstly, I'd like to thank Dr. M.B. Agarwal and AstraZeneca for allowing me to be here today. Uh, Let me start with saying, since I happen to be a molecular geneticist, it always gives me huge pleasure these days, especially to give a talk wherein I am able to bring out the need and the utility of molecular genetics. So the last couple of decades really have underscored the importance of why is it important to study molecular genetics. Firstly, to know the disease, then to control the disease, and of course, to treat the disease. And the same holds good in the case of CLL. We now know in very, very unequivocal terms that it is very relevant and very important to study the molecular genetics of CLL to manage our patients in the best possible manner. What is also very clear is that there is really no one single technology that can provide us all the answers. So when we look at which are the most important parameters in this scenario, we actually need to resort to multiple technologies. So there is interphase FISH to look at the deletion of 11q or deletion 17p. Then we need to do sequencing, whether one does it either by the traditional Sanger sequencing or NGS. But it is important to study sequencing of TP53 and IGHV. And it was really interesting to hear the panel discussion and the talks prior to that, because frankly, though it is so clearly enumerated in so many places, that it is important also to do and study the point mutations of TP53 as a standalone lab. What we find is that, of course, by and large, whenever a panel comes to us for screening for CLL, the FISH testings and karyotypings are most often asked, but the point mutations for TP53 and IGVH, not in as many percentage of cases. And one would really like to see and increase there, because the data really shows that this is of so much of importance. Also important that FISH, at least in the setting of CLL, is not a diagnostic test. It is a prognostic test which provides information basis which then the clinician can manage his patients better. So I have already discussed about this, that which are really the important markers for CLL, and also the fact that there are multiple technologies that one would need to make use of to study them adequately. The fact that the FISH is not a diagnostic test but a prognostic test for CLL is something which needs to be remembered, because sometimes we do get cases which are they send it across and we are asked to make a diagnosis basis this, which it is not capable of. What it can, of course, adequately answer is how well a patient may or may not respond to therapy. And so if a patient shows up with a deletion of 13q, then we know that it is associated with good prognosis, whereas markers of 11q deletion, or the most important one, 17p deletion, show very, very poor prognosis. This is just a representation of what a deletion of 17p would look like on interphase FISH. So in a normal cell, we have two signals for 17p and two for the centromere. And here we see a loss of the 17p locus, which of course means poor prognosis. When we come to studying the point mutations which are important in CLL, namely the P53 and the IGHV, it is either Sanger sequencing or NGS which can help us. The point mutations in P53, again associated with poor prognosis. We know that during the initial diagnostic workup phase, the incidence rate is very, very low. However, if the patient again comes back at the stage of relapse, or if the patient is refractory, then this becomes important. We are quite used to thinking that a mutation always means deleterious, but in the case of IGHV, it is actually quite the opposite. So the presence of point mutations in the VH region is a marker for a more mature cell and hence a less aggressive clone. How exactly this is defined is that after one performs the Sanger sequencing or NGS, one compares it vis-a-vis the germline sequence. And if there is a mutation, if there is a variation, sequence variation of more than 2%, then it is considered as mutated, and we report that the patient is IGHV mutated, and this carries a good prognosis. The CLL IPI score, it's a weighted scoring system based on 5 risk factors. And again, I would want to draw your attention that, we know that the greater the scoring, the higher the risk group for the patient. So patients typically of 0 to 2 or 3 score may not require treatment, but then thereafter patients of higher scoring would require. And the presence of a deletion in 17p, which ideally means that there is a loss of TP53, by itself carries a score of 4. So it directly puts the patient in the very, very high risk subcategory. Let's now see how really all these parameters and these factors help the clinician in making a decision as to how to treat his patients. So let me start with patients who are treatment naive. This here is the CLL-8 trial evaluated immunotherapy with fludarabine and cyclophosphamide with or without the addition of rituximab. And what we find here is that surely treatment with FCR as compared to FC showed us better results. But what is also important here is that patients who had these deleterious markers, such as either the presence of 17p deletion or an unmutated status for IGVH, these are the patients, the ones they performed poorly across all subgroups, whether in the FC or the FCR arm. And so this here is important, followed by, we find that 11q deletion also shows bad progression-free survival. The E19, I think I missed out something here. Okay. The E1912 trial, this compared treatment with a combination of ibrutinib and rituximab versus the standard FCR treatment. And again, what we see here is that the IGVH unmutated, which is the poor prognosis subgroup, here the combination of ibrutinib and rituximab showed good progression-free survival as compared to the FCR. In fact, like the hazard ratio is something close to 0.28. The next, the CLL14 trial, this addressed the efficacy of the BCL2 inhibitor, the venetoclax. And the two arms of the trial, they used obinutuzumab along with venetoclax or obinutuzumab along with chlorambucil in untreated CLL patients. And the results here, what they show is that the percentage of patients with progression-free survival, this was higher in the OV arm, the ones in blue. And this held true across the deleterious subgroups. So what we see here is that whether or not the patient was IGVH mutated or unmutated, both these groups benefited as compared to treatment with OC. Here again, we find that TP53, which is the most deleterious of the groups, here also the arm of OV benefited patients with TP53 deletions. The Illuminate trial, this compared the efficacy of the combination of ibrutinib plus obinutuzumab versus chlorambucil and obinutuzumab. And what this slide shows the result that the progression-free survival observed in patients within the high-risk genetic profile. And this actually has a combination of patients which either show deletion of 17p or deletion 11q, TP53 point mutations, or the unmutated IGHV status. We find that all of these show a very, very significantly high progression-free survival as compared to the other arm. The Resonate 2 trial compared efficacy of two of the oral agents, ibrutinib and chlorambucil. And again, what the graph that we have here is for patients of unmutated IGHV, which typically show poor prognosis, and the progression-free survival, if I compare the two arms of chlorambucil and with ibrutinib, we find that with ibrutinib, the patients are showing a much higher progression-free survival as compared to patients of unmutated IGVH, which are here. So very, very significant improvement. Similarly, data from Elevate and Ascend trial, it has shown that acalabrutinib shows superior progression-free survival across all subgroups. And this includes the ones with complex karyotyping, with the IGVH unmutated status, with deletion in 11q, with deletion 17p, and the ones with bulky disorders. Briefly, I would move on now to patients which are relapsed or refractory. Let's see what are the options available to us and how does the presence or absence of either TP53 mutations or IGVH affect the status here. So these are results from the Resonate trial, and they again show that consistent progression-free survival, good survival benefit are seen with ibrutinib. And again, this is for patients. I mean, just look at those graphs, whether the patient has unmutated IGVH status or the mutated ones does not really seem to make a difference here in this category when the patient is being treated with ibrutinib. So the benefit is really very, very consistent across subgroups. Again, similar situation we see here for patients who show a complex karyotype. The Helios trial here, it compared bendamustine plus rituximab with or without the addition of ibrutinib in patients who've been previously treated with CLL and either have shown progressive disease or patients who are refractory. So here again, what we find, I would want to draw your attention to this particular graph here, which is for stage 1 to 2 patients that are being treated with ibrutinib plus BR. And in the combination, what we find here is that the patients are showing great progression-free survival. And also the assessment based by an independent review committee showed that, again, this benefit was consistent across all subgroups. So it showed similar effect in patients which had unmutated IGVH status, and P53 mutations, so on and so forth. A central which evaluated response with acalabrutinib versus Idela plus rituximab, or Benda plus rituximab, again in relapsed or refractory patients. What we see here in the graphs is superior progression-free survival in both of these poor prognosis subgroups. The one here with either the deletion in 17p or point mutations in P53, and the one here with an unmutated IGVH status. Again, here what we find is that in the arm of where the patients are treated with acalabrutinib, there is a superior progression-free survival, and these, again, hardly any difference at all between patients who either carry mutations in the IGHV or they do not. So very, very good response here. So this is really like, a compilation of what and where we are. So what I would want to do is, this really underscores the importance that it is important to adequately do a diagnostic and a prognostic workup of the patients, so that one is armed with all the information and all the knowledge, because now we really do have the treatment tools of treating our patients basis what genetic lesions they carry within. So thank you so much for your patient hearing.
Well, thank you, Dr. Sarjana. You want to show your last slide? Thank you, sir.
Yes, thank you.
Thank you.